Computed tomography, or CT, has become a powerful diagnostic tool in the field of radiology. In this module, we'll review the basic principles of CT. Our 4 objectives are to discuss the process of CT image formation, radiation dose, contrast use and management of contrast reactions, and terminology for describing changes in CT morphology. All contemporary CT scanners use multiple detectors. The original scanners produced in the 1970s used a single detector. A single scan was performed in up to 30 minutes, with processing times up to 2 hours. With today's multi-detector scanners, examinations can be performed within seconds and processing times within minutes. A tube produces X-rays which pass through the patient. Similar to plain X-rays, the degree of X-ray absorption depends on the density of the tissue. The unabsorbed X-rays pass through the patient and reach the CT detector. The tube and detectors spiral around the patient and move in the craniocaudal axis. The body region scanned is divided into voxels. Each voxel is assigned an individual density depending on the amount of X-rays passing through that part of the body. There are several advantages of a multi-detector CT. The first advantage is improved spatial resolution. With an increased number of detectors, voxel size becomes smaller, resulting in improved detail. This becomes most apparent in the craniocaudal or Z-axis for reconstructions in the coronal or sagittal plane. When there is no loss of spatial resolution for reconstructions in any plane, the voxels are referred to as isotropic. The second advantage of a multi-detector CT is increased temporal resolution or faster scan times. With increased numbers of detectors, a larger volume of tissue can be imaged with each rotation of the tube and detectors. As a result of the technological advancements in CT, advanced diagnostic applications have evolved. CT coronary angiography is a good example of this. Improvements in both spatial and temporal resolution have optimized diagnostic image quality. CT coronary angiography is a powerful screening tool in assessment for coronary artery disease. After the scan has been completed and data calculated for the density of each voxel, different algorithm filters can be applied to optimize imaging for specific tissues within the body. Different windows and levels are selected to optimize contrast resolution when viewing specific tissues. Common filters and windows used are soft tissue, lung, bone, and liver. Images can be reconstructed in any plane. Traditionally, standard orthogonal planes are used in the axial, coronal, and sagittal planes. 3D reconstructions can also be performed to replicate normal gross anatomical appearances. In the next section, we'll discuss radiation dose associated with CT. CT has one of the highest radiation doses of all radiological modalities. The ALARA principle, as low as reasonably acceptable, is adopted by all imaging departments with regards to radiation dose. In pediatric patients, alternative imaging options which do not utilize any ionizing radiation, such as ultrasound and MRI, should be considered. When imaging the chest in female patients, bismuth breast shielding will help reduce radiation dose to the breast tissues. CT radiation dose depends on several factors: the volume of tissue scanned, the patient's body habitus, and acquisition settings. The international unit for effective radiation dose is millisieverts. Ionizing radiation associated with CT is hazardous in pregnancy. Radiation of any kind, including CT, should be avoided during pregnancy wherever possible. A common diagnostic dilemma during pregnancy is assessment for pulmonary embolism. CTPA is the investigation of choice when assessing for pulmonary embolism, and has a reduced dose when compared with nuclear VQ scanning in both the first and second trimesters. As the fetus moves closer to the chest in the third trimester, CT has an increased effective dose compared with nuclear VQ scan. If CT imaging is required during pregnancy, shielding should be used. In the next section, we'll discuss contrast use and the management of contrast reactions. Contrast agents help optimize imaging assessment for most tissues within the body. Contrast can be administered intravenously, orally, rectally, or via an IDC into the urinary bladder, depending on the indication. Non-ionic iodine agents are commonly used for IV contrast administration. These can be low in osmolarity or isoosmolar with plasma. IV contrast should be administered via an IV cannula. This can occur via a pressure injector or by hand. In certain institutions, IV contrast can be administered through a central venous line via a hand injection. There is a risk of damage to a central venous line if IV contrast is administered through a pressure injector. Depending on the delay post-IV administration, imaging can be performed in single or multiple phases. Commonly, imaging is acquired in the arterial, portal venous, and delayed phases. There is a risk of contrast-induced nephropathy in patients with deranged renal function. Blood tests should be checked to ensure that the eGFR is greater than 30 and serum creatinine levels are less than 0.15 micromoles per litre. Several measures can be taken to reduce the risk of contrast-induced nephropathy. These include adequate IV hydration, reduced contrast volume, and the use of isoosmolar agents such as Visipake. Diabetic patients taking metformin have a small risk of lactic acidosis after the administration of intravenous contrast. For this reason, it is recommended that metformin is ceased 48 hours after the use of IV contrast. Once blood tests prove renal function to be stable, metformin can be recommenced. A reaction to IV contrast by any patient should be documented to ensure it is not administered in the future. In most institutions, consent is required before the administration of intravenous contrast. It should be noted the previous belief of cross-reactivity between seafood allergies and contrast allergies has been disproven. IV contrast allergies can be classified as severe, intermediate, mild, or delayed. Whilst rare, severe reactions, including anaphylaxis, are potentially fatal. Urgent resuscitation is required. The initial medication of choice is IV adrenaline. Severe IV contrast reactions are reported in less than 1 in 20,000 patients. The most common intermediate contrast reactions are bronchospasm and an urticarial rash. Bronchospasm can be treated with inhaled beta-2 agonists such as Ventolin. Urticarial rashes can be treated with oral antihistamines. Mild contrast reactions include nausea, vomiting, and pruritus. The most commonly reported delayed contrast reaction is a rash, which usually resolves spontaneously. Oral contrast is usually administered between 60 and 90 minutes prior to the CT examination. This ensures the contrast material has reached the large bowel at the time of the scan. Either positive or neutral contrast agents can be used. Positive oral contrast can be useful in differentiating intraenteric content from extraenteric collections. In the setting of trauma, positive contrast agents can also be used to help identify penetrating injuries to the gastrointestinal tract. Neutral oral contrast can be used to assess morphological changes in inflammatory bowel disease. In the setting of suspected gastrointestinal hemorrhage, neutral oral contrast is used because a positive oral contrast agent may obscure the site of IV contrast extravasation, which represents the site of bleeding. Reactions to oral contrast agents are rare and are usually related to iodine-based contrast agents. If a patient has a known iodine allergy, barium-based alternatives are available. Rectal contrast may be useful in identification of a sinus or fistula. It may also be administered to assess for a penetrating injury of the rectum. Typically, 1 litre of diluted contrast is introduced via a rectal tube under gravity. A CT cystogram is the investigation of choice in detecting bladder injuries in the setting of trauma. 250 to 500 ml of diluted contrast is introduced via an IDC under gravity. In the setting of trauma, an IDC should never be inserted by any clinician, including the radiology department, until there has been a urological review. In the next section, we'll discuss general approaches to changes in CT morphology. When an abnormality is detected on CT, terminology for describing the morphological changes include location, size, density, structure, shape, demarcation, mass effect, and perfusion. Location refers to the side of the body and/or segment within the tissue of origin. All CT images are displayed with the patient's right on the left side of the image. Size can be measured in 3 dimensions: AP, transverse, and craniocaudal, or expressed as the maximal diameter in one plane. CT density reflects the opacity or lucency seen on plain film. Areas in the body which absorb fewer X-rays appear black, while those that absorb most X-rays appear white. Each voxel is given a designated density. Air has a density of -1000 Hounsfield units. Fat has a density of -100 Hounsfield units. Fluid has a density between 0 and 10 Hounsfield units. Soft tissue has a density between 10 and 100 Hounsfield units. Bone has a density of between 100 and 500 Hounsfield units. An elliptical region of interest can be used to measure the specific density of an abnormality. Alternatively, density can be described relative to the normal tissue of origin. Hypodense means darker, and hyperdense whiter than the adjacent normal tissue. This axial CT demonstrates a hyperdense right subdural hematoma. Thrombus has a density of between 30 and 70 Hounsfield units, and increases in density with increasing age of the thrombus. Conversely, hemorrhage reduces in density with increasing age. Acute hemorrhage has a density between 30 and 60 Hounsfield units. Chronic hemorrhage has a reduced density between 0 and 10 Hounsfield units. Metal has a density of 1000 Hounsfield units. The structure of an abnormality may be focal, geographic, or diffuse. Structural changes of pathology can be described as homogeneous, meaning uniform structural abnormality, while heterogeneous means non-uniform or mixed structural abnormality. Changes in shape can be described as tubular, nodular, reticular, oval, or diffuse. The margins of an abnormality may be well-defined or ill-defined. An abnormality may have no mass effect, positive mass effect where it displaces normal structures away from the abnormality, or negative mass effect where it pulls normal structures towards the abnormality. This image demonstrates a right acute subdural hemorrhage with positive mass effect and midline shift to the left. IV contrast enhancement is described relative to the density of normal tissue with normal perfusion. Reduced enhancement refers to reduced density relative to normal tissue correlating with reduced perfusion at the time of imaging. Increased enhancement refers to increased density post-contrast relative to normal tissue correlating with increased perfusion at the time of imaging. This coronal CT demonstrates a hypodense mass extending inferiorly from the liver with peripheral enhancement. This concludes our module outlining the basic principles of CT. We've discussed CT image formation, radiation dose, contrast use and management of contrast reactions, and terminology in describing changes in CT morphology.